have people who started the course right from the beginning, particularly Rodolfo, but we're very pleased to welcome back Jorn Olsen, who's come back to give us a lecture on this last morning. Before we start, I'd particularly like to thank, at the back, excuse me, Ma and Sarah. Ma is in the office in Barcelona. And Sarah is in the office in Basel. And we'd also particularly like to thank Katarina and Eleanor and all the staff at the studio. But some of us have been coming here a very long time, so I remember when the trees were very small and you had a much better view, whereas now we just see the trees. And it's been interesting how the course evolves over the years. Of course, we have a new young generation of teachers like Lorenzo, but some of us have been coming here a long time, and we've sort of noticed as us older teachers get older and slower, the students seem to get younger and healthier. You're probably the hardest working, most sober group we've ever had. That's not a compliment, that's an observation. It used to be on the last morning when I was going to breakfast, I would trip over a drunken student from the night before. Now you trip over someone doing Pilates out on the deck. So it's a generational difference. We're doing a couple main things this morning, but starting with the Saracci lecture. Now, as Rodolfo has observed, he's still alive. It's unusual to name a lecturer after someone in that state, but Rodolfo is a very special friend to all of us and has started this course and has been here for many years, and we wanted to do something to commemorate what everything he has contributed and all the ways he has helped us in other ways over the years. So this is the second annual Saracci lecture. It's slow. Is it still downloading? Okay, so I'd like to introduce Olof Akre, is that pronounced correctly? To give the second annual Rodolfo Sorachi lecture. So welcome.
Thank you very much. I feel humbled and honored to give the Rodolfo Sorachi lecture of 2018. I once was a student here in 1996, so it's 22 years ago, so I remember when the trees were a little lower. In fact, Lorenzo doesn't remember that the trees were lower, so he was probably one of the students you were stepping over in the mornings. But I wasn't, so I get to do the Saracchi lecture. But then coming back to Sweden, I did my PhD on testicular cancer epidemiology, supervised by a professor whose name is Anders Ekbom, quite well-known researcher in Sweden. And I continued doing epidemiology and teaching and starting up a school for clinicians in epidemiology. A 20-week course that runs over 2 years in Stockholm at Karolinska Institutet. And nowadays and I was really inspired by this course and the program at this course program when I built that curriculum in Stockholm. And now there are also thousands of clinicians in Stockholm who had gone through similar experience as those 2,000 that have been here over the years. But in the end, I turned surgeon, or urologic surgeon, so I do prostate cancer surgery half-time and research on tumors in the urological sphere half-time. So my perspective here, I don't think I can sort of give you any methodological secrets in epidemiology in this room of people, but I will sort of look at the interface between surgery and epidemiology and the observations that I've been doing surgery and also evaluating the outcome of surgery and specifically the outcome of new surgical innovation using epidemiological methods. But I wanted just to start with some important public health problem that is emerging and has to have a quick, I think, intervention. It's not actually about Neymar, who spent 14 minutes on the field, lying down in these 4 games. Actually, against Mexico, he spent 5 minutes and 29 seconds, and he's leading in this league. But I think it's the collateral damage coming from this that is really a public health problem. Because I started counting the number of viewers of the World Championship, and normally it attracts half of the population in the whole globe. So, assuming that there are 2 billion viewers on every game, and that you live 75 years, I made the calculator to calculate the burden of this injury in the global population. And I'm happy to share this calculator if you want to do other kinds of calculations. But just a few stat bytes from this calculator gives us that corner kicks cost 225 lives per game, substitutions 150, penalties and VAR, the new video-assisted referee function, are not that expensive in terms of lives, actually, as people may think they are. Goal celebrations, however, spend 150 lifetimes in one game. Imagine it's 48 games in one championship, so we're talking tens of thousands of lives here. But injuries actually spend 210 lives per game, and Neymar alone per game, 175, and against Mexico, 275 lives were spent. So I made this yesterday, and I started to think, what's the population attributable risk? I want to be very epidemiological about it. And how many lives can we save if we remove Neymar from a game? I mean, it got a bit complex, but there's a lot of smart people in here, so I'm sure somebody can help me out, and we can publish something on this. So now to the main topic. So everybody is probably familiar with this pyramid, the hierarchy of study design. I guess this hierarchy of study design was created by epidemiologists. Correct me if I'm wrong, you might have a more historical perspective on this, but I suppose that this was the work of an epidemiologist. But I think we created a monster, really. I hope some of you agree with me, but this has become a big problem for us because this has become the only truth. And in fact, most of our hypotheses and ideas can't be assessed using these hypotheses. So then it becomes totally, it's a waste of time to say that there's a lack of randomized controlled trials in this case. And also the development of evidence-based medicine has sort of marked all other studies as totally irrelevant, which is, to me, a big problem. So I think we should try and work, when you come out in the world from this EEPE summer course, you should try and work against this and say to people, use your brain and not the recipe all the time. Because we tend to stop thinking when we have these rules of thumb, and I think this is a big problem in evaluating new treatments in general. But if we turn to surgical research, we have the opposite situation. So in fact, surgeons are slightly unaware of these types of studies above case series and case reports. And in fact, the top level of evidence is the expert opinion. Because surgery is a technical thing. It's like a carpenter with a master and a trainee. The person in a room of surgeons with the highest credibility is always the best carpenter, regardless of a scientific background. This I've seen so many times in different meetings, conferences in the surgical community of both urology and general surgery. And in a way, it makes some sense because there's a reason why they are considered the best surgeon, sometimes at least. And so they might actually have a point. But the problem in the discussion is that when in the surgical community, when you have a discussion about a new surgical technique and it's been evaluated and they said this one was better than the other, there's always a couple of surgeons who raise their hands and say, well, in my hands, this is a good procedure. The one that you're saying is not a good procedure. So the discussion becomes impossible. So we have like two different worlds here with the canyon in between, so that we have the evidence-based medicine and we have the surgical world here. And I'm trying to bridge this gap most of the time. I feel sometimes a bit lonely, I must say, because to these guys, I'm just a surgeon, and to these guys, I'm a lousy surgeon. And to these guys, I'm also a sad epidemiologist because I'm not spending. And I also feel frustrated because I try to do two careers at the same time, and it's impossible. So in the end, you feel most of the time like an incompetent epidemiologist or incompetent surgeon, depending on where you're swimming around. Now, in a way, you should compare yourself with those that are worse than yourself. So you're a good epidemiologist among surgeons and good surgeon among epidemiologists. But I tend to have the other perspective. Okay, I'm going to take two examples of two different surgical innovations or techniques that came up during the latest decade, starting with a more historical perspective of the laparoscopic cholecystectomy and going further with robotic surgery in urology, which is where I do work. This operation is about removing the gallbladder because you have stones in the gallbladder, and then you can have this gall colic, which is common, especially in women in the middle age. It's associated with high BMI, but it's a very common condition, and it's if you have had one or two of those attacks, or if you've even had the cholecystitis, which is an inflammation of the gallbladder, there's an indication to remove the gallbladder. So this was done with this incision, and of course with your hands, a knife and scissors. But then came the laparoscopy. And then you, instead of making this big hole, you make 4 small holes, and you work with long instruments. And of course, the scarring. So for the patient, mainly the scarring is the issue. So that's what the patient see. But for the surgeon, it's also about surviving and so on. But the patient is unaware of this. But for sure, this looks much more nice than this operation. And I can imagine that it's very likely that this person will spend more days in the hospital than this one. And this was also true. All the other surgeons also imagined this because, as you can see, this is just from Scotland. I found some historical figures, but it was the same boom everywhere. So the first laparoscopic procedure was done in '85. Scotland took a few years to wake up, you could say. But then once laparoscopic procedures started, they became the majority just in a few years, 2 or 3 years. And you can also see that the total number of surgeries went up because probably because you judged that it became a much more sort of good low-risk surgery. However, it is not a low-risk surgery, really, because there is a very bad complication in 2% of the cases, which is that you injure the bile ducts. So you get bile leakage into the abdomen, and then you can spend 2 months, 3 months in the intensive care unit, and the mortality is quite high, actually. And that kind of complication for a benign operation is a difficult situation, because a benign surgery should not come with very high risk complications, of course, because you always do this balance between benefits and risks. But I'd like to focus a bit on how the stages of surgical development happens, because it's very different from what you see in medicine. Because you know this, in medicine you do a lot of work in the labs, and you do animal studies, and then you do the phase 1 where you test the doses and toxicity, and then you do phase 2 and phase 3 and phase 4 and all that. Surgical development is much more wild in this respect. So somebody has a good idea and tries it in surgery, ideally starting in an animal, but not always. I guess it depends a bit on how dramatic change it is about. But then the high volume experts go to conferences and pick up this, and they go home and try themselves this new way to do. They buy a machine, perhaps. And then, because they're high volume, they do a series of 200 patients. And then they go to the conference and tell the other surgeons that I did this, and in my hands, with well-selected patients, this is a very good and safe procedure. Okay, so patients start asking for it, and finally, it's adopted by all surgeons. But it's not all surgeons, because, of course, there's a big gradient in this, because if it's an expensive machine, there will be, of course, big differences between sort of the Western world and the developing or the low and intermediate income countries. But in fact, also within the high income countries, there are big social inequalities in the distribution of the new technique, because what will happen is that over this development, at some point, both patients and doctors start to think that the new technique is so good that it's unethical to do a randomized controlled trial on this. And this happens very early on in the development of surgical procedures. And then the pressure from the patients and from the doctors gets too high, and then it's suddenly adopted. The thing is that the EBM, the evidence-based medicine people that are actually deciding, for example, especially like in countries where you have a strong guideline authority, like in UK, they see no signs of evidence that this is better than the other, and they say you can't have it in the insurance system. So what will happen is that the private patients will pay for it to have it, but whereas the rest of the population, those that can pay, will have the old school technique. Sometimes maybe better for the rest of the population, because the new technique might not be better, actually. We don't know that, but most of the time the development is in a good direction, and then it's of course to the benefit for those that can pay for it. In cholecystectomy, the first cholecystectomy was done, the open version was done in 1882. So 103 years later, they launched the laparoscopic version. So when we had 103 years of experience of open cholecystectomy, we started to do lap, and then 6 years later, these are citations from different articles in surgical journals. saying that randomized controlled trial lap versus open is ethically unjustified due to obvious advantages of the lap procedure. And it's difficult, if not impossible, to conduct. So just in 6 years, we came to this position or in the development. Okay, let's look at the suggested benefits. So doing lap instead of open is suggested to make you stay shorter post-operatively in the hospital. You will have less post-operative pain, shorter convalescence, smaller scars, and fewer complications. This was what was suggested. However, there was also suggested, mainly by those that were still in the open procedure, of course, that there might be an increased frequency of bile duct injury, so serious complication, 2%. And this was, of course, there were big fights in the surgical conferences, but nobody could come up with the evidence. Until these guys from, I think they were from Sheffield, I forgot to check, but I think it was a team of surgeons in Sheffield that did, UK, that did this, I think, very nice randomized controlled trial of lap versus open cholecystectomy. It was published in The Lancet in 1996. So they randomized 200 patients, one-to-one, in the operating room. So what they actually did, that they gained informed consent with the patient. They took the patient to the OR. They initiated the anesthesia, and then they did the lottery. So the patient was put to anesthesia without knowing whether it would be an open or a lap procedure. And then they had 4 trained surgeons that did both procedures and were considered to be competent in both procedures, luckily. And after the operation, the treatment information was in sealed envelope in the post-operative ward. And they had identical surgical dressing, and they put blood stains on all the dressing, so it looked very much alike. Yeah, I have rarely seen similar careful design of an RCT in the surgical world. There might be a reason for that, but okay. So what did they find? I'm sorry, this slide, of course, this is from 1996, so it's a scanned page. But I can tell you that they compared operating time to first solid, semi-solid feed, hospital stay, time off work, return to full activity. And the results show mainly that the only difference is that it takes 15 minutes longer to do the laparoscopic version, and there was no clear difference in the other variables. Or no relevant kind of difference. So in fact, the patients were allowed to return to work whenever they felt like it. They were allowed to return home whenever they felt like it. And it was very similar in the 2 groups. You could ask, is 100 patients compared with 100, does it give the enough power to actually detect relevant differences? I won't go into that discussion, but this is a reasonably small study, admittedly. Okay, and if we looked at bile duct injury and other kinds of complications, it was 12 versus 14. And of course, randomized controlled trials are not good at detecting rare complications, as you know. So if you would do some check for bile duct injury, you need a register of thousands of operations, of course, in an observational setting. But that wouldn't be a big problem because it's an unintended effect. So in that respect, I think observational studies are really good at comparing to surgical methods. It's just there might be some confounding by indication going on. Okay, Richard Horton, the editor of The Lancet, wrote a commentary with this headline: "Surgical research or comic opera? Questions but few answers." And he was not really impressed by surgical research because he did a survey. He went through surgical journals, I think 9 surgical journals, and checked for a few issues back and checked what's the percentage of studies with comparison groups, etc. And he found out that 46% of the studies were case series or case reports, and I think 18% were animal studies. So it was a very strong statement that surgeons need to shape up and start doing science. But I think there are a few questions here to be asked. So now we had this series of case series studies and these bold statements about cholecystectomies before this study, and then came this randomized controlled trial showing no differences. Did we stop doing cholecystectomies based on this? Well, of course not, because we already had bought the machines. The patients wanted it, the surgeons liked it, and as they said, in my hands, this is a safe and quick procedure with better outcomes in well-selected patients. They always have this well-selected patient clause in the end. And you could also ask, was this a good or a bad development? Well, nowadays we have thousands and thousands of observations of this surgery, and I think careful analysis of observational data of complications suggests that adjusting for preoperative risk factors, bile duct injuries in the end was fewer or lower frequency than in the lap procedure than the open. So in that respect, for cholecystectomies, it was a good development. And then also, this aspect is interesting in surgery. If you launch a technique on a sort of a benign, kind of easy operation, you can then transfer it and scale it to other kinds of surgical procedures. So nowadays in urology, we do nephrectomies. So instead of doing this, we do a few holes here and bring out the kidney under the umbilicus, with much less postoperative stays and much less pain and so on. So there is also some collateral benefits of introducing a new technique that are very relevant in this in the surgical innovation development. So had we treated this like a medication, we might have stopped, and that might have been a bad decision. Probably a bad decision. And also, I'd like to raise the question, okay, we did a randomized controlled trial, and it was laparoscopic versus the small incision, so they did as small a wound as possible in the open arm. These groups look similar, but are they? So, in fact, the open surgeons, they were 4 surgeons, as you know, that did both procedures, but they had much more experience of open surgery than laparoscopic surgery. So when they defined experienced in laparoscopy, it meant that they had assisted or performed at least 40 procedures. 40 procedures, and I think I've done 40 procedures, and I'm a urologist, so and I wouldn't consider myself experienced in this respect. These groups, they are randomized with their baseline risk of outcome, but the surgeons, the allocation of surgical expertise is not randomized, even if you have the same people doing the surgery. And I'll come back to this, and I'll move on to robotics in prostate cancer. And I have to tell a few things about prostate cancer surgery, because it will be relevant to how we evaluate the technique later on. But in prostate cancer, as you know, the prostate is situated as far down as it can go in the abdomen, or even below the peritoneal cavity. So it's right on the pelvic floor. And this is a prostate, and this is just a part of the urinary bladder, and what you see here is the seminal vesicle. So the urethra runs right through the prostate, and in the apex of the prostate is the sphincter that keeps the continence of the male. So and if we do a section of the prostate like this, so we look at an axial projection of the prostate. This is a schematic axial projection. I have drawn a tumor here, and to show that the tumors are mainly placed in the dorsolateral parts of the prostate. So this is dorsolaterally of the prostate, and these dots here are sections of the bundles of nerves and vessels going to the penis and taking care of both, mainly of the erectile function, but also a bit involved, probably, we think, in the continence. So in cancer surgery, you want to remove the tumor radically. You don't want to cut so you get the so-called positive surgical margin. So you want to have radical removal of the tumor, but the more radical you are in prostate cancer surgery, the less your postoperative function will be. So you always have this balance between removing the tumor entirely and having good functional outcome postoperatively. So it's also that when you dissect the apex, you tend to shorten the sphincter and also injure the sphincter a bit, so the function goes down. And the more radical you are down here, the less your urinary function will be later on. So there is a balance between function and radicality constantly. This is what we always talk about in prostate cancer surgery. And for a long time, we did this prostatectomy for prostate cancer. There is a long discussion whether that is whether there is a good reason to do that operation as well. But I leave that totally behind now and say that, okay, for some patients, the prostatectomy saves lives and also prevents metastasized disease. And this was done with an open procedure with a 10 to 12 centimeter wound below the umbilicus. And then you had to put your hands down here to the prostate, which is here, and you had long instruments, and it was you have to look down like this to see what you're doing. So it's a kind of a not so nice position to work in for 2 hours. And then they tried to do this laparoscopically, but it was never a big success because it's so far down. It's so far down in the pelvis, so it's difficult to maneuver down there with these long instruments because the long instruments don't have any wrist, so they are totally stiff. So you can rotate them and move them like this, and you can use the scissors and the forceps, but you can't move around in the narrow area of the pelvis. So instead of traditional laparoscopy, in 2001, 2002, they started doing robotic laparoscopic radical prostatectomies instead. And then you put the ports just like you do in the laparoscopy, but instead of doing traditional laparoscopy, you put this mean machine to these ports here, and the surgeon is sitting in the console doing the work with joysticks here and pedals. And I'm going to show just what it looks like because it has also some relevance. I hope you're not too sensitive about these things, but it's not so nasty. Okay, so this is from a radical prostatectomy. I just wanted to look. Is it reasonably visible? Should we? Yeah. So, so what you get from this surgical technique is that you can come very close to where you're working with magnification up to 5 or 10 times, and then, as you can see here, you can work with the scissors in different angles, not just straight, but you can work in different angles, and like this. In fact, this is not a true robot. It's called the master-slave machine. So the master is in the console and the slave is doing the work. And so what is done here is that he's dissecting. This is the peritoneum here, and we're dissecting these white spaghettis here, which are the vasa that vas deferens that takes the sperms produced from the testicles to the prostate and to the urethra eventually through the seminal vesicles. So, and I think just think about what are the potential benefits of using these instruments instead of your hands and your eyes, because this is going to be the key to whether it's better or not. Okay, I think I'm going to stop here.
This is the actual speed.
It's the actual speed, yes. Yeah, I think he's going a bit slow, this surgeon. I don't know, but yeah, careful person. I can tell from just the movements, which is of course good in general, but it takes also time, and time is also of interest when you do surgery. You don't want to have person in anesthesia for too long and so on. Okay. And as you can imagine, this looks really fun. It's like playing a video game. It's but with high stakes, you could say, the patient's health and life. But still, for a surgeon, a nice technique. So surgeons were easily persuaded to do this, and there was an industry. There's been a company called Intuitive Surgery that has had monopoly for this machine for now 17 years. There are coming competing firms now, probably launching next year. So then perhaps the price of this operation will go down and approach what is in the open surgery. But in Sweden, the average price for an operation like this instead of an open is 2,500 euros higher than the open surgery. So it's a lot of money. But this was adopted not as quickly as the laparoscopic cholecystectomy, but it went from below 10%. This is in the US to 78%, and Sweden has, I think we passed 80% in 2017 for the proportion of prostatectomies that are done with the robotic assisted radical prostatectomy instead of open radical prostatectomy. And it's all over the world, in many places, very common. There's a lot of Indian hospitals that are developing this technique. They do kidney transplantation with this. South Koreans do a lot of thyroid surgery using the robot. And in urology, we do kidneys for kidney cancer. We do bladders for bladder cancer. So and they do cholecystectomies. They do laparoscopic robot-assisted colorectal cancer surgery, mainly the parts that are close to the prostate, far down in the pelvis, so the low rectal cancers. But this was every surgeon thought, most of the surgeons thought that this was a very promising development and felt like this is the new black in prostate cancer surgery. So this happened, and when surgeons tend to think that they are good to sell to the patient this idea also. So the patient is totally, I mean, the patients will want it because the surgeon wants it. There's an information asymmetry. Okay, but when evaluating prostate cancer surgery, you need to evaluate both radicality and function. So how was this evaluated? And it's been mainly, of course, in case series, as always. But in Sweden, we did an observational cohort study of this to study whether both function and radicality is improved by using robotic surgery instead of open. So this study was called LAPRO, and the cases were recruited in 2008 to 11. It was 2,500 men, 2/3 doing robotic surgery and 1/3 doing open surgery. And the main endpoints were, of course, positive surgical margins, so lack of radicality, and quality of life, so in terms of continence and erectile function. And there was patient-reported outcome measures with the questionnaires. We had a fantastic study secretariat. I think it's over 90% response frequency from the patient. So very well-conducted study technically. And here are the main results for all three outcomes. So positive surgical margins, 22% versus 21%. This relative risk. For pad use, which is the main measure of continence function at 12 months, so when you have recovered from the surgery in terms of continence. So here you can see most people were without pads, but some percentage had less than one, 10%, and 13 had less than one per day, and 13 and 12, and there's some here, and then it becomes this more severe type of continence problems are 1 in 20 or 1 in 15 or something like that. Erectile function, as you can see, is not so good. So the dysfunction was 70% in one arm and 75% in the other arm. If you ask a patient, the priority list of this would be, of course, removing the tumor, 2, having continence, and 3, having erectile function preserved. But in this population, men are between mainly 55 to 75. And in the upper age classes, erectile function is sometimes not a high priority because they have a low erectile function preoperatively. There was basically no difference in pad use, no difference here, a slight difference here to the benefit of robotic surgery. And also they checked complications, and it was a bit more blood transfusions in the open arm, so a bit short-term complications were a bit more common in the open arm, but nothing dramatic. And so the year after came a randomized controlled trial from Australia by Yaxley, John Yaxley, and they randomized 326 men 1-to-1, and it was just one surgeon in one arm and another surgeon in the other arm. And the primary endpoint was, at this point, functional outcomes. So they're still following up for other outcomes, but this was the early publication. And again, there was basically no difference between the groups for robotic versus open. So the urinary function score measured with the EPIC form for prostate cancer and the same sexual function, it was no relevant and no significant difference. So is this the end of the story? Well, no, it isn't. But just let's have a look at the differences between the arms in this study. So in this case, the open surgeon had done 1,500 procedures, and the robotic surgeon had done 200 procedures. That's a big difference in surgery, because in 200 surgeries, you're still a bit on your learning curve, but that's not true for this case. So you could also say that, well, this study, because they concluded that there is no clear difference between the techniques in terms of functional outcome at 12 weeks postoperatively, but you could also conclude that despite a large heterogeneity in the surgical experience, you reach the same functional outcome with both techniques, so to the benefit of the robotics surgeon. And this discussion has been very hot in the urological community ever since. And also in our study, the LAPRO study, the open arm was, because it was gradually abandoned, the open technique. So the open arm was to 40% dominated by one super high volume surgeon, the one with the best reputation in Sweden. So he was pretty heavy in this analysis. So we started thinking, how can we separate the technique from the craftsmanship? Because this is really, in surgery, a big problem and a complex problem. This is from the LAPRO study. The different surgeons, every line here is a surgeon with his mean and confidence interval, and this is on the x-axis the probability of being potent at 24 months post-operatively. Down here is the sum of, so let's see, these are robotic surgeons and these are open surgeons. So on average, you see that they are not very different, but as you can see, in both the open and robotic arm, the variation is much bigger between the surgeons than between the group of surgeons. Yeah? So how to separate? And this is continence function. So here's the distribution of open, and here's the distribution of robotic. So how do we actually evaluate the technique? Well, we started to think about the movie I showed, how you operate with the robotic machine. What is actually the advantage? And we were starting to think that, well, the advantage is, 1, you see better what you're doing. 2, you have better control over your maneuvers. And what could that lead to? Well, it could lead that if you have a strategy with your surgery, you may have a better possibility to follow that strategy through your surgical procedure. So we checked whether the surgeons had, whether they were following their plan and whether the outcome was sort of associated with their plan to do the surgery in terms of function. So what you see here is the robotic group, and here is the open surgery group, and on the x-axis is nerve sparing. You know the nerves are passing right on the dorsolateral side of the prostate. So if you do nerve sparing, you might have a non-radicality, but if your aim is to have a nerve sparing surgery, is actually the patient also having better function. So this is showing sort of the correlation between what the surgeon says he or she did and the actual outcome of the patient in terms of function. And this is at 3 months, 12 months, and 24 months after the surgery. And as you can see, with gradual increase in nerve sparing degree in the bilateral, both left and right side of the prostate. So with the increasing degree of nerve sparing, there was an increasing functional outcome for the patients here, but much less of a correlation in this group, especially in the early parts. So that indicated to us that, okay, so open surgeons, they have a plan, but they may do a bit of the same operation regardless of their plan, because they don't really see what they're up to. And if they do so, they have problems in sorting out the different delicate layers in the prostate. And then we thought, okay, but the strategy is different depending on the preoperative clinical situation. So in high-risk prostate cancer, radicality is much more important because these patients will have a quite high risk of dying from cancer if we don't remove the tumor with margin. So we have to have a strategy that's prioritized radicality in high-risk surgery, whereas in low and intermediate risk, it can be discussed because these patients, even if they get a recurrence, they will live perhaps for 15 years, 20 years, and they need to have a reasonable quality of life. So, in fact, evaluating robotic prostatectomies on average might not be the correct thing to do because the goals vary depending on the preoperative situation. So then we checked, what about the positive surgical margin by risk of group, preoperative risk group. So in the complete data, the risk of having a positive surgical margin was equal in high and low risk. In the group where we did robotic surgery, the risk of having a positive surgical margin was much lower if you had a high-risk tumor than if you had an intermediate-risk tumor. And whereas if you did open surgery, it was the inverse. And of course, this is what we want to have. We want to have better radicality in the high-risk group. And if you just don't have a strategy, this is what will happen, because it's at baseline higher risk to have the positive surgical margin if there is high-risk tumor, because it's going to be a larger, bulky tumor that is going out of the prostatic capsule and easier to have a positive surgical margin. So in fact, overall, it looks like it balances out, but specifically by risk category, we did more the right strategy in terms of radicality in robotic surgery. And this also showed in the risk of having biochemical recurrence. If we look at the positive surgical margins overall, there was no difference. But if you look at the risk of having a biochemical recurrence, which means that you have a measurable PSA postoperatively, the risk was higher in the open group, and it was a significant difference. And especially so for those tumors that were bulky and grew outside the prostatic capsule, there was a quite significant difference, both in positive surgical margins and biochemical recurrence. And likewise, in function. So this is the erectile function, and this is a graph of, this is all patients, this is intermediate and low-risk patients, and this is high-risk patients. So if we start looking at all patients and we see the development of erectile function postoperatively, you see at 3, 12, and 24 months, there's a gradual increase in erectile function here, and it's slightly better here than there. But this difference here is attributable only to a difference that it's in the intermediate group. Because in the high-risk group, we don't care so much about functional outcome because we prioritize radicality. And we had a similar result regarding continence. So this data, of course, it's observational, it's subgroup information. It was not the pre-specified primary endpoint of the study, because the primary endpoint was average. But as we can see now, the average comparison was incorrect because the aim of the surgery is different depending on the preoperative situation. So in our view, I should be transparent with the fact that I do only robotic surgery and not open. But we had more radical surgery in the high-risk prostate cancer and more function-sparing surgery in the low-risk prostate cancer. At least we managed to have better data on the patients afterwards. But on average, these effects canceled out. And the story right now, if you read the journals, is that these techniques are equally good. There is no evidence of any difference. But this is mainly based on the randomized controlled trial. But what I want to say here is that when you evaluate new innovations in surgery, it is complex to separate the handicraft from the craftsman. And if you do a randomized trial, you will get published in The Lancet. You will have strong credibility. Everybody will think you're coming up with the truth. But in fact, it's a deceiving quality mark in this case, because randomization works in terms of baseline risk if it's a large study, but it doesn't work in allocating treatment similarly across the arm. You don't allocate the technique, you allocate also the carpenter in the randomization. So I think what you have to do is that you have to understand what are the technical advantages in the new technique. What is really the key of the potential benefit of a new surgical technique, and you have to design your endpoint accordingly, and also design how you measure the endpoint accordingly, and also pre-specify your subgroup analyses. So plan detailed analysis of the kind that I was showing, I think is key to go behind the traditional kind of simplistic approach that we have that is coming entirely from the evaluation of medical treatments. I put a reference here for there is actually this problem. Jan van den Broek has published on these discussions about surgical innovation, and there are nice publications in the Lancet that I happened to read last night. Thank you for the information. And you do an attempt to really structure this problem. But I just want to say that to me it's about having the person doing the surgery to be able to define the exposure and the outcome. And to do so, I think it's not about trying to have these guys turning their triangle in that way. It's about teaching these persons to do good epidemiology. That's going to make a change. So we can have a structured and a sort of that we implement new technologies in a structured way. So I did my start in 1996, and there is plenty of training going on in surgeons now. But I think surgeons need to train in epidemiology, and there is the attitude I meet is not always very positive to epidemiological methodological knowledge. But this is, to me, the main solution, because it's very difficult for an epidemiologist to tease out the technical advantages and design a study based on that. And it's impossible for a surgeon to design a study, and those two groups are too far from each other today to communicate. So I think there's a need of people that has both languages and that can communicate and understand what's going on in surgery and translate it into epidemiological study design. I'm going to stop here, but I didn't want to end with Grand Canyon. So, because I know, Rodolfo, you are interested in opera. This is the Drottningholm Palace Theatre in Stockholm. Have you been there?
I have been running.
You've been running the machine.
When there is the storm, so they call me back. I mean, and then I had doing the wind and the storm, and running in that old 17th century technique of doing that.
It's one of the few operas from 1700s that have original machinery. So when you do the thunderstorm, there's a box with rocks rolling around. It's very scary. When you listen to a Rameau opera and you hear rocks rolling around, you get really scared, I'm sure. And there are also ugly clouds coming down from the 1700s here.
So maybe they picked up me there.
Maybe yes. But it's one of the few with original machinery. It's from 1754. It's a wonderful place, isn't it?
Yeah, and so I'm very thankful that you showed that.
And finally, thank you so much for your attention. This is our winter house in April up in the north of Sweden. So thank you so much.
Thanks very much, Olof. And it's time for coffee, but I think we can take a few minutes for some quick questions or comments.
Jan van den Broek, may I just comment on your overall message? To try to have two types of knowledge, the epidemiological one and the clinical one, into one brain, which I think is very important, because then that one brain will see things differently, will come to different solutions. I think we need all three types of people. We need the pure clinicians. Pure clinicians nowadays, they cannot read their own clinical journals anymore because the statistics have become too complicated. But when I'm ill, I like to have a clinician who is not able to read the clinical journals anymore because the statistics are too complicated. We need pure methodologists and biostatisticians to develop methods and to interact with clinicians. But in the middle, we need the people who have both types of knowledge in one brain, because it's almost impossible to communicate that you see epidemiology differently if you have the surgical brain and vice versa, so to speak. You see surgery differently, as you clearly do if you have the epidemiological brain. And secondly, I couldn't emphasize much more than you do that it's very important to go into the depth of the problem and then to specify what really is the point that you want to make. And then your study derives from that. Thank you very much for this lecture.
Thank you. Thank you. I couldn't say it better. In one brain is the answer. It's too... there are too many 100%ers around trying to solve this problem, but designing a study is not about methodology only, and it's not about clinical knowledge only. You need both in the same brain to do good study design.
Well, thank you very much, Olof. It was fantastic to follow this talk. And I wonder, I mean, you are a younger generation of surgeons who have these double brains or combined brains. How does it resonate in the younger community of surgeons to actually call for what you call a more structured way of implementing new techniques, which sounds very, very good. And I think if they agree, you can go that avenue.
Yes. I think it's attractive to younger surgeons who are less tainted by the history, so I think a lot of young surgeons are interested in this now, and especially in Sweden we do a lot of quality healthcare registration to assess our healthcare quality. I think we have 140 quality registers in different diseases and for all the cancers. So we specifically assess at baseline and during follow-up different clinical characteristics. And this data, of course, opens up for evaluation, and it's data that's prospectively collected and readily available for studies. And to use these data, you need this kind of competence. So a lot of young surgeons or urologists and also general surgeons in Sweden are interested in learning epidemiology these days. But there's still a long way to go.
We'll take one more question.
I would like to elaborate on what you're saying, Jan. I think it's right that it's very important that you have both specialities, but I think the other thing we are learning from this is that it's not one person designing a study. It is really teamwork. And what I would encourage you to do here is to try to set up a framework of how do you answer the right question and put that out into Lancet to really pinpoint how did you actually get to the right question. But because to me it sounds as you did that post hoc. Yes. But what we want to do is to get there before we do the study. And you have the experience now, and I would encourage you to write it up and let other people get that experience.
Thank you. Rodolfo, any final comments on the opera? Or
No, I just found it. I just found your lecture fascinating. So thank you, and not for the Drottningholm, apart from that, really for what are you doing. And it's inevitable at my age, the thing goes back suddenly. Remember, one of the very first things in which a surgeon came close, and it was something very important. I mean, was Veronese in Italy for the breast cancer treatment, when he proposed that rather than doing the Halsted radical, taking out everything, I mean, you would even take out the thoracic cage of the woman, he said, well, we can just take out a piece of the breast. And he ran a clinical trial, and I have a slide. He came and consulted me, the young epidemiologist, it was 1966, again, 50 years ago. He said, what is the sample size in order to show that the survival of these women is going to be as those of the radical? And all the surgeons were saying, this is unethical. You are going to kill the... My answer was, of course, if you want identical, that with the sample size is infinite, by definition. You have to specify how much, and he carried forward. That was one of the very first things. I mean, and there were two groups in Italy and in Boston, and that is changing completely the prospect, as you know much better than me, on the radical intervention for breast cancer, really. That was mid-60s, I mean. So there is always some pioneer there.
Okay, thanks very much for a fantastic talk, and we're about 10 minutes late for coffee, so let's start again maybe 11:05. Thanks very much once again.